I am. Anytime.
You're good.
Hi, good evening. I'm Kathleen Digre. I'm a professor of neurology and ophthalmology here at the University of Utah. And I welcome the people who are here in the room, but I also welcome all of you who are at home. We're going to be talking about migraines across a woman's lifespan because it's a woman's disorder. So if you look at these three people, I don't know if any of you know who these people are, like Whoopi Goldberg, Virginia Woolf, even Queen Elizabeth. All three of these women have migraine. And so tonight, we're going to be talking about migraine in a woman's life. First, we're going to talk about sex differences in migraine and other primary headache types. We'll also discuss menstrual migraine, pregnancy and headache, menopause and migraine, and then we'll talk about some special considerations that we have to think about. If you look at this graph, you will notice, come on in and welcome. If you look at this graph, you'll notice that migraine occurs most commonly in women starting in their pubertal area, time period between 10 and 14. Is the fourth most disabling condition and about the 8th most disabling condition for men. And as you know, there are many different kinds of migraine, migraine with aura, migraine without aura, and migraine with aura is more common in women. In this picture, you can see a typical aura with a zigzaggy appearance, often starting small and moving out. And almost 16 to 17% of all individuals have migraine with aura. It may be more common in mountainous states like Utah.
Why do you think that is?
So we have. So the question was, why do we think that it could be? We think it's related to altitude. We're in the process of studying altitude and migraine with aura. There are other major sex differences in migraines, such as chronic migraine, meaning that somebody has migraine more than 15 days a month, or a month, is 3 times more common in women than in men. And migraines tend to be longer in women than in men. Even though men and women may get the same number of attacks, they can last longer and they can be more severe. They often have more severe accompanying symptoms, such as light sensitivity, nausea as well. And migraine in women is associated with more comorbidities. What do I mean by a comorbidity? I mean depression, even bipolar depression, panic disorder, anxiety, and even obsessive compulsive syndrome can be more common in women with migraine than in men. It's interesting that women also get more tension type headaches than men. About 71 to 88% of women have experienced a tension type headache in their lifetime versus 50 to 69% of men. And women have a higher prevalence in all age groups, and but white women tend to have more tension type headaches than African American women. In cluster headache, we always think of cluster headache, which is a very specific kind of headache. It's unilateral, usually over an eye, doesn't last as long, 20 to 40, 60, 90 minutes, associated with tearing and a red eye and droopy eyelid. We always think of that as a man's headache. But in all honesty, women have cluster headache almost as frequently as men. Perhaps men twice as much as women, but the problem is that women don't get this diagnosed as often because everybody thinks of this as a disorder that's seen in men as opposed to having been seen in women. Now, medication overuse headache is also 2 to 5 times more common in women than in men. So women tend to have this medication overuse headache more frequently as well. And the kinds of medications that can cause overuse headache are opioids, things like butalbital or things like Fioricet, Fiorinol, and even triptans can cause medication overuse headache. And this is a very chronic headache that sometimes is very difficult to treat. And then I want to bring up sexual abuse in childhood, which is it also occurs more frequently in women. Almost 30% of women who attend headache clinics have had a history of some kind of early childhood maltreatment, whether it's physical abuse, emotional abuse, sexual abuse, or some type of abuse. And it's really important to understand that. And we've done talks on that in the past. And sleep disorder, it usually accompanies this problem. And women who have this present a very challenging treatment conundrum for all of us. Now, I'm going to start taking us through migraine across the lifespan. So I'm going to start with migraine in menstrual-aged women in puberty. Then we're going to talk about migraine in pregnancy, and then we're going to talk about migraine in menopause. And I thought what we'd do is use a case. This is Lily. She's 14 years old, and she is presenting with worsening migraines since she started menstruating. And she has regular periods, and her headaches start about 2 days before the menses until 5 days after her menses. And for Lily, that's really disabling for her because it always occurs at one period of time in her life. Now, there's 2 kinds of menstrual migraines that you need to understand. And some people say, oh, I have menstrual migraine. But pure menstrual migraine is not that frequent. It only occurs a few days before the period and a few days after the period. That's pure menstrual migraine, and that's not that common. But menstrually related migraine, and you can see that only 1% of individuals get pure menstrual migraine. Most people get this menstrually related migraine where it comes around the time of the period, but it could come at other times too. But people who have menstrually related migraine, they say, I can count on a migraine during my menstrual cycle. And that's menstrually related migraine. That occurs in about 7%. However, about 70% of all women with migraine will get a migraine sometime during their menstrual cycle. So, you know, there's a week before the period, there's a week of the period, there's a week after the period, and so, you know, defining this exactly is sometimes a challenge. Now, where does this menstrual migraine come from? Well, if we look at the cycle, and this is looking at estrogen and progesterone, so the estradiol here is in the dotted line, okay? So the estrogen is in the dotted line, and the headache is in the darkened line, the black line, okay, the continuous line. And you can see that that you get an estrogen spike before you ovulate, and then your estrogen falls, and as that falling occurs, that's when menstrual migraine occurs. So the falling estrogen seems to be a trigger, and this has been shown in many studies, for the menstrually related migraine, okay? Well, you can see, and it's a challenging migraine to have, especially for Lily, because menstrual migraines sometimes are longer. For Lily, it lasted 5 days, sometimes more severe, and sometimes more resistant to treatment. Sometimes they're associated with aura, but not always. In fact, sometimes they're not. You don't get an aura before that. In pure menstrual migraine, we usually say you have to have 2 to 3 consecutive cycles where you only get your migraine just in that period of time, between about 2 days before the period to about 3 days after the period, and you don't get migraine at any other time. Does that make sense? Okay. But menstrually related migraine, that is, it still occurs in the same time, but that means you always get a migraine during the menstrual cycle, but you can get migraines and headaches at other periods of time as well. Now, both menstrual migraine, pure menstrual migraine and menstrually related migraine can respond to triptans, which are acute therapies for migraine. The other thing that we have in our armamentarium is what we call mini prevention, and I'll talk about that. We can also give somebody a daily prophylaxis to prevent migraine. Now, when I see people with menstrual migraine, I frequently will put them on a preventative because, or pure menstrual migraine, I just use a mini prevention. But if they have menstrually related migraine and they're having migraines at other times through the month, they need to be on a preventative through the whole time. And then we'll talk a minute about menses suppression, about suppressing the menstrual cycle. So how do we choose what to do? So in general, if there are infrequent migraines, only pure menstrual migraine, then we will probably just take an acute abortive therapy, okay? But if it's not pure menstrual and it's more frequent, then we're going to talk about long-term prevention or some kind of short-term prevention for those menstrually related migraines. And the two drugs that have been studied in menstrual migraine are rizatriptan and sumatriptan. Rizatriptan goes by the trade name of Maxalt. Sumatriptan goes by the trade name of Imitrex. But you can see that these have been studied during menstrual migraine and have shown a pretty good success rate for treatment of the menstrual migraine. Now, what is a mini prevention? So a mini prevention is something that you take 2 days before the onset of the period to 3 days after the period starts. And a mini prevention option that's been studied, frovatriptan has the best evidence. It has grade A evidence. And usually we use the 2.5 milligrams twice a day, 1 day before the onset of the period to 4 days after the onset. Other triptans have been looked at, naratriptan, zolmitriptan, and naproxen has been used, which is over-the-counter Aleve, as a preventative during that. And then sometimes people have used estrogen throughout the menstrual cycle to suppress the menstrually related migraine. Many other migraine preventatives work for menstrually related migraine, and we have grade A evidence for beta blockers. We don't like to use valproic or divalproics in young women because there's so many side effects, and if somebody gets pregnant, it can be teratogenic. Topiramate has also got grade A evidence. We can also use atenolol, amitriptyline, venlafaxine. Cyproheptadine is also, or periactin has been used. And then there are other drugs that we do in migraine prevention that have varying levels of evidence. So the question is, if you suppress menses, can you suppress migraine? And so people have looked at that, and the person who's really done a lot of work of this is Anne Calhoun. And she has studied different strategies to treatment. One strategy is to use a low-dose oral contraceptive with supplemental estrogen during the menstrual week. And that suppresses menstruation in many women. And sometimes it keeps that estrogen from falling and giving the menstrually related headache. A second strategy is using extended cycle oral contraceptives. These are contraceptives that go on for 8 to 12 weeks, and then having a menstrual week with supplemental estrogen. And a third strategy is to put using a natural menstrual cycle and then apply an estradiol patch during the expected time of the period. And then another one that she has done and written about is using ultra-low combined contraception over a long period of time and suppressed it. In general, doing hormonal manipulation for some people is helpful, but for a lot of people it causes trouble. And so I have not done a lot of hormonal therapies only because it seems to create more trouble than it's worth for some people. Now there's some people who really have done well with this, and I never argue with them, and I support them in what they're doing. What about oral contraceptive use in migraine? And I do want to bring this up, since people with migraine have a very slightly higher increased risk of stroke, very small, but people with aura, migraine with aura, have an even higher risk of stroke. But when you add oral contraceptives to migraine with aura, the risk goes 15 to 17-fold. The real problem comes is if a woman has migraine with aura, oral contraceptives, and smokes. Smoking creates 34 times risk factor for getting a stroke. So migraine with aura plus smoking equals bad. So you don't want to smoke, that's not good. But also that combination of aura and oral contraceptive can increase the risk of stroke. It seems to be a little high, it seems high, but the absolute risk is not that high. And with the newer, lower estrogen-containing contraceptives, this risk may not be as much. There's no evidence for migraine as a risk factor for stroke in women over 45. This is just younger women on oral contraceptives with aura. And again, the lower estrogen pills probably will reduce that risk. Then there's the progestin-only contraceptive pill that's been used. And this was a study where they did progestin-only pills in menstrually related migraine and just migraine in general. And they both groups did fine. And this may be an alternative for those with migraine with aura and wanting to be on an oral contraceptive to do the progestin-only pill. Any questions about oral contraceptives or menstrually related migraines?
I have
Yes.
a question. Just because of I don't know if it's a true link of estrogen and breast cancer when you add estrogen into your system.
Okay, so the question that's asked is about estrogen and breast cancer, and there is a study, and this is so controversial, as you know.
I know, and so maybe we don't open that can of worms, but
It is controversial. Studies would suggest that people don't want to be on, if they have breast cancer and they have estrogen positivity, they aren't going to want to be on estrogen, right? If their tumor is, and often breast cancer is treated with drugs that suppress estrogen. So estrogen and breast cancer is a hot topic. And I think what you're asking is, would estrogen make it more likely for you to get breast cancer? And that's really
there's some studies that suggest
even more controversial, because some people do believe that it does increase the risk, especially in menopausal women, but the data are kind of mixed. Okay? All right, now let's talk about Alyssa. She's 32 years old. She's having her first pregnancy. She's a person who's had migraine. She's had chronic migraine. She is in early pregnancy, and she wants to know, how is the migraine going to affect my pregnancy? How is my pregnancy going to affect my migraine? And what do I need to know? Well, the first thing is, you always want women who are of childbearing age to see their doctors and talk about pregnancy before you get pregnant when you have migraine, because many women get put on many medications for their migraines, and then some of these medications can be bad during pregnancy. So I always think, and it's really important for any woman who is thinking about pregnancy or is sexually active, to talk to their doctor about, could this be a problem for me? Well, anyway, Alyssa's pregnant, and now let's just talk about this. What is interesting about migraine and headache in pregnancy is that, 20% of all women have migraine, and of course women get pregnant. Most women get better during pregnancy. Only 8% get worse. So most women, during the first trimester they can get worse, but during the second and third trimester they often will get better. And this is shown in this graph, that during the trimesters the estradiol level does increase, but the headaches often get improved, they remit. So in the first trimester, only 45% remitted. In the second trimester, 83% remitted. And in the third trimester, almost 87% remitted. So in other words, many women do get better during pregnancy. And this is probably related to the high estrogen state, and the estrogen is not falling. So what do you think is going to happen when the pregnancy is over?
It's going to be horrible.
Yes, it does come back. It does come back. You're absolutely right. So there are women who get worse migraines during pregnancy, and I've seen so many women start with migraine with aura or even complicated features to their migraines during pregnancy. The pre-pregnancy headache pattern usually returns right after being pregnant. And another thing that I've noticed, nulliparous, which means they haven't been pregnant before, multiparous means they've been pregnant before. The more kids you have, the more headaches you have too. So in people who've had several pregnancies, their headaches tend to get a little bit better. The best predictor of headache during pregnancy is, what was your headache like before you got pregnant? Now, how does headache impact the pregnancy? Well, they've looked at this question, and some women have a higher incidence of preterm birth related because they've had migraine. Another finding that's been shown is that some have had a slightly elevated blood pressure during pregnancy. And it is true that women with migraine are at slightly higher risk of getting preeclampsia or eclampsia. This is a pregnancy disorder of hypertension during the pregnancy, and characterized, by very high blood pressure, proteinuria, and it's can be a serious complication of pregnancy. So what do we do about treating headaches in pregnancy? Well, the first thing is, before you get pregnant, you want to really plan this out. And I suggest women who are planning pregnancy with migraine have a conversation with their headache specialist, but also maybe with their obstetrician. So, and people can work together. I love working with obstetricians on women who are wanting to get pregnant or are going to get pregnant, because I want to have that headache as well controlled as possible before they get pregnant, or at least, and be on a medication that's not going to cause birth defects or anything else. All women of childbearing age should be on folate. Folate is a vitamin that prevents neural tube defects, etc. All women of childbearing age should be on folate before they get pregnant. And then one thing that I can't stress enough is how important a healthy lifestyle is to everybody with migraine, but especially somebody who's contemplating pregnancy. Sleeping well every night, eating a regular diet, exercising every day. That healthy lifestyle is important for all patients with migraine, but when you're getting pregnant, that's even more important. And we really push sleep, nutrition, stress reduction, of course avoiding alcohol and nicotine, and then consider things like biofeedback or relaxation or mindfulness training. Now, there are medications that can be used in pregnancy, and the system that we use is an old FDA system. A means perfectly safe, use with impunity. What drugs do you think are like that? Almost none, okay? B means probably safe, no problem, it's been studied, etc. C means no bad things, but we really don't know. D means there are some bad things, don't use it unless you really, really, really need to. And X means don't use it under any circumstance in pregnancy. So that's the system that the FDA came up with labeling drugs in pregnancy. Most drugs are C, meaning we really don't know. So acetaminophen, C. You think Tylenol is very safe, but it's still a C drug. Acetaminophen, aspirin, and caffeine, a C drug. Okay, that's like Excedrin. DHE, ergotamines are X drugs. We don't use any ergotamines in pregnancy. Ketorolac, which is a kind of non-steroidal like naproxen or ibuprofen, are all C drugs. And even butorphanol, which is a narcotic, and everybody thinks narcotics are safe, but that's a C drug as well. The next level of drugs that we use, and all of these drugs, that list I gave you, have been used with evidence, level A evidence. Level B evidence, these are more medications. Some of these are for nausea. As you'll notice, many of them are C. Metoclopramide is a B drug, so it's been studied, it's pretty safe. We use a lot of it for nausea in pregnancy. These are antiemetics. Magnesium is often used for people with preeclampsia and preterm birth, but for migraine as well, but it's not a very, it can be a difficult drug on bones. Acetaminophen with codeine or Tylenol 3 has been looked at, and tramadol and with acetaminophen has also been used.
What's an example of a DHE drug? Like what's a name?
Dihydroergotamine. It's an ergotamine, so Cafragot, ergotamine. It's an old medication. We don't use it very often, but dihydroergotamine is one that we often use for chronic migraine, but that's an X drug. We wouldn't use that. Opioids, everybody used to think, oh, opioids was what you should use in pregnancy, but this can be associated with heart defects, spina bifida, and of course the opioid crisis from all the opioid use in our country going up. It's one, opioid overuse, and not necessarily abuse, but use is one of the highest causes of death, maternal mortality, even in Utah. And Utah has actually got a big problem on opioids as well. One thing I wanted to bring up during pregnancy is occipital nerve blocks. The drug that's used is called lidocaine. It's a B drug, so it's pretty safe. And it's injected into the back of the occipital nerve and can stop a bad migraine. So there's studies that are being done now with these occipital nerve blocks in pregnancy, and this has been found to be fairly helpful for people. Now, triptans. Triptans is what, as you know, we use triptans all the time for migraine treatment. And it's been studied in pregnancy. In fact, in this study, 4,200 infants with triptan exposure were studied and compared with over 1.5 million with no triptan exposure. And there was no increase in major birth defects, prematurity. There was a very slight increase in spontaneous abortions early on in pregnancy, but that was a very minor amount and did not reach significance. So this meta-analysis, it was a big study that looked at many different triptans: sumatriptan, naratriptan, zolmitriptan, elatriptan, rizatriptan, provatriptan, and that's what they found. So a lot of people do use triptans in pregnancies. They're level C, meaning we don't know, but some people feel comfortable using triptans in pregnancy. What about prevention? Normally, we like to go with non-pharmaceutical treatments. meaning diet, lifestyle, sleep, mindfulness, those kinds of things. There are some devices out there that are non-pharmacologic, which have not been studied in pregnancy but are presumed to be pretty safe. One is a stimulator of the forehead. It's a kind of a trigeminal stimulation on the forehead called the Cephaly device. It's something you wear for 20 minutes as a preventative, and also you can use it acutely. But it has an electrical current, and for some people it's been successful. Another device is the vagal nerve stimulator, which is applied to the vagus nerve by the carotid. Again, it's not a medication, and so some people are looking at these kinds of devices. And we do sometimes use daily medications, especially if the headache is really severe. And I can't stress the non-pharmacologic diet, sleep, exercise, weight control, limiting caffeine, because this is so important for everybody.
Quick question about the vagal nerve stimulator. If you were to vagal yourself, in adults, I know that in infants that causes a Brady episode. Is that the same for an adult? Like a big parasympathetic, like would your heart rate drop?
Okay, so the question, I'm doing this for our home people. So the question is about the vagal nerve stimulator. Would it cause your heart rate to drop, like getting a vasovagal?
Right.
And the studies have shown that it's been very safe. People have had very few side effects, and it has not caused fainting.
So no implications for perfusion?
No implications for perfusion that we know of, right. It's been very safe, studied. Some people swear by it. It's been approved for episodic cluster, for migraine, for acute migraine, and for some people it really works well. So it's another thing in our armamentarium that we can offer people that's not a medication and another treatment for people to use. So, and you're going to get sick of my saying this, but the lifestyle modifications, I'm not whistling Dixie on this. This is really important, okay? Cognitive behavioral therapy has been shown to be as successful as a preventative medication for migraine prevention. And that's without pregnancy, but with pregnancy as well. And that, especially if you find a very good person who does true cognitive behavioral therapy, and then these nerve stimulators that I've been talking about. There are other nerve stimulators. There's a patch now that's just been approved, Nerivio patch, that was just approved. And there's some other devices that are coming along the market that probably will be helpful, especially in pregnancy. So when do we offer prevention? Well, if you have a headache more than 6 days a month, that's pretty severe. However, let's say you have a headache only 2 or 3 days a month, but you're completely out. Well, then we've got to do some kind of prevention. And besides our lifestyle preventatives. So what medications are out there in pregnancy? So again, most of these are C, some of these are D, one is B. And you can see that there are some medications, propranolol, metoprolol, that are used. We don't use divalproex in pregnancy at all because of neural tube defects. Topiramate, we avoid that drug also in pregnancy because of cleft palate. And amitriptyline we do use. It's a C drug. Venlafaxine we use. Cyproheptadine is a drug we've used in kids. It's got a B rating in pregnancy. But for some people that's successful. Verapamil, gabapentin have been used. These are both C drugs. And then the injectables, like I said, the occipital nerve injection with lidocaine has been used in pregnancy. Sphenopalatine ganglion blocks. This is with lidocaine as well. You block the sphenopalatine ganglion. That sometimes works. Trigger point injections are also with lidocaine, a B drug. And then the onabotulinum toxin, the Botox treatment for migraine, which is approved for chronic migraine, has not been studied extensively in pregnancy. It has a C rating. And this is one where you really have to have a discussion because we really don't know if there is a chance of a problem in pregnancy, but it is rated C.
Can I ask a question?
Of course.
Injectables? How long do those last? Are they, is it
On a botulinum toxin?
just any of the injectables, or is it something that?
Okay, how long do the injectables last?
Yes.
Good question. All right, so let's go back. So the occipital nerve blocks are usually given with lidocaine, and the half-life of the drug is pretty short. However, for some people, it kind of shuts down some of the mechanism for the headache for a period of time. Some of these phenolpalatine blocks, even though the mechanism of action of the drug itself may be short, it sometimes can shut the process down for a period of time. Trigger points, sometimes if we anesthetize trigger points and bring all the pain down, we get improvement of headaches in general. It's not perfect, and they don't last that long, and for some people, you know, they get the block, they go, oh, it's great, and then the next day they're right back at it. So everybody's a little bit different, but it's sort of it's nice to know about what are the tools in the toolbox that can be helpful.
Right.
And then onabotulinum
What about the Botox?
So onabotulinum toxin is given once every 3 months.
Okay.
That's how long it lasts. I didn't talk about the calcitonin gene-related peptide antibodies, and that's because we don't know anything about them in pregnancy whatsoever. We are not recommending women who are planning to get pregnant to use them because there are CGRP receptors, you know, all through the body, and we don't know what effect that could have on pregnancy. So that's erinumab, like Amavig, Emgality, or galcanezumab, and fremonizumab or Ajovy, eptimizumab.
So how long, if you did that, those injectables, how long in years, I mean, would you have to let it get out of your system for certain?
Okay, the question is, if you were to take a CGRP monoclonal antibody, how long would you have to wait before you got pregnant? And the answer is we don't know. I would caution a person to maybe wait 3 months, just to be careful. Usually it's a month. You know, one of the CGRP antibodies is good for 3 months at the higher dose. That one for sure I'd wait 3 months.
What about in people under 18 years of age? Because I saw it was a warning, like, do not use under 18.
Okay, so the question is about under 18, whether you can use the CGRP monoclonals, and the answer is it's not been approved by the FDA for use in children. However, there are articles out there about the monoclonals being used in adolescents, but they don't have an FDA rating on it. But some headache clinics will be giving that to adolescents with the understanding that they've tried other things and they've failed, but they are studying it in younger age groups. So that answer, I hope we'll know in the future. Well, what about postpartum? Well, here the problem is headaches come back. They come back usually to the regular level after pregnancy, and then of course you've got a new baby at home and you're up all night. Well, what does lack of sleep do to anybody with migraine? Boom, you get more migraines, okay? And there's a small increased risk of other headaches coming in that postpartum period of time. Most people, it's just the return of their regular migraines, but people can get secondary headaches. I also like to mention about breastfeeding and lactation. There's a lot of different information out there. There is this book that is called Medications and Mother's Milk. It's probably the best book out there. And we have a hotline here at the University of Utah you can call, and they have a lactation hotline, and you can ask about any drug in pregnancy, but any drug also in with lactation. They'll help you with that. So migraine is not a contraindication to nursing. So people with migraine can nurse, that's not a problem. Many of the triptans have been considered safe by the American Academy of Pediatrics in infants, sumatriptan, zolmitriptan, and also many drugs are safe to use as prevention. What's interesting about lactation is some drugs that we use during pregnancy maybe aren't as good during lactation, but some drugs that we don't use in pregnancy may be used because it's the amount of protein binding and how closely bound it is to a protein, whether it goes into the milk or not. And so that's where one should check on the safety of drugs during lactation and work with a pediatrician and also check on these drugs. And this is just sort of a list of proven safe drugs, so acetaminophen, ibuprofen, L-triptan, caffeine, some of the other drugs. We don't usually use those ergotamines for lactation either. At least that is what's recommended, not to use the ergotamine. Triptans are probably safe. Any question about pregnancy, postpartum? And I do want to just mention that any woman who gets a new headache during pregnancy or postpartum should talk to their doctor, because there is a small increased risk of secondary headaches. And this is just a graph that shows that most headaches are primary headaches, or this great big blue part of the pie, 65% are primary headaches. But there are other causes of headaches during pregnancy that can occur. So I always tell people that if it's your typical headache and you know it's your migraine, great. But if you get a new headache in pregnancy, then be aware, talk to your doctor, because I want you to make sure it's not one of these secondary headaches, because there are many different things. Pituitary problems, venous sinus thrombosis, et cetera, et cetera. But most of the time, all the headaches we see in pregnancy and postpartum are going to be primary headaches, which is going to be migraine or tension type headache. Preeclampsia is something that is more, as I said, increased risk of preeclampsia if you have migraine, up to 4 times, and there's a slight increased risk in stroke. Now I'm going to take us to, we've gone through menstrual cycles, we've gone through pregnancy, now let's go to menopause. So this is Susan. She's 60. She's had several children, and she has a history of migraine without aura. She started having migraines around puberty, age 14. It improved during pregnancy, and in her 40s, her headaches became more unpredictable. They used to be very predictable, and she started propranolol for a preventative, and then she went through menopause around age 51. So, menopause usually occurs in the mid-50s. During this perimenopausal period, so late 40s, early 50s, migraines can get pretty irregular, and just as menstrual cycles get irregular, headaches can also get irregular and increase. Many people after menopause, their hormones are going to decline. Their estradiol, their estrone, and all these hormones decline steadily. And even testosterone, women have testosterone, that declines. And then a chemical in the brain called luteinizing hormone and follicular stimulating hormone, they increase. So this is a chemical that's in the brain that increases. But headaches can become much more unpredictable, and they can become worse during this perimenopausal period of time, probably related to a lot of the hormonal shifts. Now people say, well, what if I take out my ovaries? Will that prevent migraine during menopause? And the answer is no. So you can still get it. What if I do a hysterectomy? People go, well, let me have a hysterectomy. Well, a third get better, a third get worse, and a third stay the same. So you really have I would never do a hysterectomy just for migraine in women. And how do we approach the headaches in menopause? Well, we think about lifestyle, of course, and then what to stop the headache. We can talk about hormone replacement therapy, migraine prevention, and then just watching to see if they will get better. Usually as a woman gets older, goes through the menopause, many women have their migraines just vanish. Sometimes people can start getting, when they can get auras without headache at all. So they can keep the migraine aura piece, but lose the headache. And that's a very typical pattern as people get older, that they get the aura, but not the headache. Now, we often talk about hormonal replacement during menopause and the perimenopausal period. We try in migraine to use a reduced estrogen dose, and there's different ways of doing it. Remember I told you all those different ways you could do it. There are patches to get more steady state. This is really a discussion you want to have with your gynecologist, because there are other things you worry about on going on hormones, as one of our participants talked about, was hormones with breast cancer, and knowing what your risk factors are and being sure that this isn't going to cause more trouble down the line. But this is a whole topic of just discussion about estrogen replacement in perimenopausal and menopausal women. So, what are my conclusions? Well, migraine is prevalent throughout a woman's lifespan. It affects women during the most productive years of their life, 18 to 45, 50. I mean, that's when we're charging ahead and doing everything we want to do, and then we get migraine, and sometimes takes the wind out of our sails. All providers need to know about diagnosing and screening for migraine and treating migraine. So you want to talk to your provider about your migraine. That's really important. And I'd say you want to talk to them as early on as possible, because not only do you want to prevent migraines, but you also, if you're going to consider pregnancy, you want to get those migraines under control before you get pregnant, and you want to be on medications that are safe in pregnancy. And there are treatments, both acute treatments and preventative treatments, that can treat migraine in pregnancy. So, but you want to be smart about it and know about those FDA classifications and what drugs are safe. And then we have many great resources. I'm going to tell you about the American Migraine Foundation is a wonderful resource to learn more about migraine. Here at the university, we have drug information that even patients can call and ask. And all physicians and providers should be helping women to understand all the different alternatives people have to treat their migraine. And with that, I want to save a little bit of time, a couple minutes, for questions that anybody here in the audience. It doesn't have to be about women in migraine. It can be anything about migraine whatsoever. And I will repeat the question for our audience also at home.
How do you know if Botox, do they still think now that maybe taking out the occipital nerve, we did this with one of my daughters, because she got a little bit better with Botox, and then we did that whole surgery where you take it out. You take out the nerves here and everything, and it didn't work.
Okay. Well, that's the topic. I will just tell you. Number one, surgery for migraine. It's not been proven. Most of the studies that have been done have not been well controlled, and many of the reports come from the surgeons and not in a randomized controlled trial. Surgery is not recommended unless it's part of a clinical trial. Okay, that's my first point. The second point I want to make about it is what nerves are people doing? There are nerves up here in the superior trigeminal, superior orbital nerves, and Botox works in a different way than removing the nerve. It is affecting the CGRP system and different fibers, in nerve fibers that we are treating. That's what we're treating. We're not taking the nerve out. We're not deadening the nerve. So taking a nerve out doesn't necessarily mean it's going to take away the migraine, because migraine is not just a peripheral problem. It's a central problem. It's in our brain. It's in the trigeminal system, which affects the whole nucleus caudalis, the whole trigeminal system. So It's not a simple take out a nerve and everything is going to be okay.
Have they ever tried like brain, you know how when people have severe depression, they'll do shock treatments?
Okay.
Since you said it was a brain disorder.
So the question is, would deep brain stimulation help migraine, or other stimulators help migraine? There is a stimulator called a transmagnetic stimulator. It's a device that's put on the back of the head. I didn't mention this in this devices, but we have a whole lecture on Headache School on devices. But a transmagnetic stimulator, it's a magnetic pulse to the back of the head at the onset of the headache, and magnetic stimulation has also been used in depression. But this has been used with migraine with aura, and it also has approval from the FDA with migraine without aura. Very few side effects. It would be something that could be, again, I think, used during pregnancy. But that is another device that could be tried. Deep brain stimulation is where you put a device in the brain. We've used this in motor disorders like Parkinson's disease. You know, this is the shaking palsy and everything. We have a target we're going after. The problem in migraine is there's many targets that we're going after, and you can't just pick and choose a little one target fits all within our brain. So this is not a prime time treatment for migraine prevention, you know, doing deep brain stimulation at this time. Maybe at some point it will be important, but for at least at this time it's not for prime time. Yes?
So I've noticed with my migraines since I have gone into menopause, they've changed. Can you talk
Yes.
about that at all?
So yeah, just what I said. So the question is, or I've been asked to comment about going into menopause, my migraines change. I hear this all the time, that either it becomes more severe, or it changes in the way it affects me,
But,
or
I mean, the location of them.
the location could
Like,
change.
It used to be like right here, and now it's like, you know, more in a
So,
different part of the head.
could the location change? Could the associated features change?
Right.
Absolutely.
Okay.
So the problem is, you know, migraines also change throughout your life. You know, sometimes they're just unilateral, sometimes they're bilateral, sometimes they can be different, one side here, one side there. They can change throughout, and many people have migraines that are experienced in different places, even in their face, okay? But in menopause, it's a real time of change. That perimenopausal area, a period of time in a woman's life is a time of change. There's hormonal changes. Sometimes there's more estrogen than less estrogen. So it's a time of hormonal change. And it's a time of change of your life. Your focuses are changing. You know, you're less in tune with taking care of little babies and kids. You're more in tune with probably teenagers or young adults that have got their own problems. Do you know, it's a time of change for us. I wish our lives came with instruction manuals. How do we live our life? And then how do we live our life if you have migraine? I mean, right? How do you, if we could have an instruction manual of how to live your life with migraine. But I do think that realizing that it is a time of change, realizing that your migraines can change, and then really concentrating on that sleep, hydration, eating well every day, sleeping well every night, you know, stress reduction, that menopausal period of time. There's a lot of stresses that are occurring during that period of time. People are changing, relationships change, families change. I mean, parents get sick, you end up being, do you know what I mean? It's a time of so many things going on in our lives that we've got to give ourselves a little room and say, you know, I'm in a time of change. It used to be called the change, if you recall from the older literature. I'm going to go through the change of life. Well, I'm afraid we're changing every day, you know?
I don't want to spend too much time on it. It's just probably just voodoo, but you know, these ear piercings,
Okay.
or you know, there's the other, what's the other big one that people talk about? Like acupuncture,
Right.
or things like that. I mean, are they just absolutely not medically indicated?
Okay.
Are they?
So the question is about daith piercing and also about biofeedback acupuncture. Well, daith piercing doesn't have a lot of data. It's not been studied in randomized controlled trials. Biofeedback has been. Mindfulness has been.
Okay,
Cognitive behavioral therapy has been studied and found to be successful. Acupuncture has been studied. So these are adjunctive therapies that can be used and mindfulness, relaxation therapy, cognitive behavioral therapy. I can't stress enough that some of these and biofeedback have been studied and have been successful. The problem is finding the right person to do the
Do you
work.
have an acupuncturist that you would actually recommend?
I can't give you the name of a specific person. We've had people say some people have been more
I
successful.
have some.
So,
Okay, I want to talk to you.
anything else?
When you say cognitive behavioral therapy, are you just talking about doing some talk therapy with?
Okay, so cognitive behavioral therapy is more than just talking about your problems or
Right,
whatever.
right.
It's talking about kind of coming up with what are some things that are either blocks or keeping headaches going, or pain blocks, or anxiety issues, fear of having a headache.
Okay, but it is in the therapy.
It's in a talk therapy, but it's a specific kind of therapy
Okay.
done by people who are psychologists trained in cognitive behavioral therapy.
Okay.
And very important to get somebody who's been trained in it, because it's not just a simple, let's talk
Right.
about your problems and work it
There's a
out.
book on Amazon. You can even
Yeah.
see what it is yourself, like, you know, because
someone comes here to teach.
oh, someone comes here to teach too.
Yeah. Anyway.
Yeah, I'm familiar with it. I was just interested in the approach that you're.
And there are different approaches used by different therapists, and many therapists use different approaches for different things. Like insomnia has a certain approach, anxiety has a certain approach, obsessive compulsive disorder has a certain approach. So they have different approaches for each of these, and that's the kind of person you want to help you kind of regulate some of these areas, these comorbidities that occur with people with migraine, especially in women. Well, good night. Thank you for coming with us today, and I'm really glad that you all were here in the audience, but also for the audience at home.